This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life, coping with back pain. More than 80% of people will suffer from lower back pain at some point in their life.
You'd wake up in the middle of the night with some back pain, but you just dealt with it because you got life to live, right?
Off and on back pain plagued this man for nearly 30 years. His journey to find relief and how diet and exercise made all the difference. Whether the pain is minor or major, our panel is here to help you find relief for your aching back.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
And welcome to another edition of Health Matters. I'm Teresa Lukens. Chances are you've had back pain at one point or another in your life. It is one of the most common reasons that people go to the doctor. There are lots of remedies that promise relief, but what really works? Our panel is here to answer that question and so much more, so let's meet them. Dr. Benjamin Howie is with Providence Orthopedics. He specializes in orthopedic sports medicine. Dr. Jamie Gore is a chiropractor with Pearson and Weary Chiropractic, Orthopedics, and Rehabilitation. Dr. Nathanial Whitney is with Inland Neurosurgery, Spine Associates. His specialty is neurosurgery. And finally, Dr. Ryan Barnes is with MultiCare Health System. He works in pain management, physical medicine, and rehabilitation. And thank you all for being here tonight. And we welcome you to join the conversation as well. You can email us your questions or even call into the show and ask our panel your questions about back pain tonight. Also, we are streaming live tonight on Facebook if you'd like to join us there. Let's begin tonight by talking about how the patients that you see in each of your practices and the type of back issues that you each see and what are some of those most common issues. Dr. Howie, let's start with you.
Sure. So my practice is primary care sports medicine, so the non-operative sports medicine. And really the big goal is to keep people moving. So people in athletics or the recreational activities they enjoy. So I don't see a lot of back pain, in all honesty, but when I do, it's really a lot of times muscular, that people get a strain out there doing their activity or their sport, or they have that and it's inhibiting them from doing what they want to do. So that's mostly what I see is kind of the muscular part of it. When it gets to the fractures and displacement, things like that, then I get them on to these guys.
Yeah, in fact, we're going to talk about that team approach tonight a lot, I think. Dr. Barnes.
So I see a large number of people with back pain of all sorts, from subacute, within 4 weeks, to chronic back pain, sometimes for decades. Back pain is, one thing I enjoy about back pain is it's a challenging disease to treat because it's very called heterogeneous. There's so many different contributors to back pain, and we see all types and try to sort it out. And in physical medicine rehab, our big focus is improving people's quality of life and function after establishing a diagnosis.
Mm-hmm. And Dr. Whitney, the surgeon on the panel tonight.
Yeah, so I appreciate what you said about team approach, because I'm often at the end of that team when people have kind of hopefully tried everything and nothing else is working, and then they come to a surgeon. And but what I actually do is, in my practice is mostly spine. So a lot of people with back pain hopefully have tried a lot of other things first, but we end up doing a lot of surgery for people who have failed all those other therapies. So very surgical, but also very niche and kind of a last resort for people.
Mm-hmm. And Dr. Gore is a chiropractor.
Yeah, that's my bread and butter, back pain. I see that day in and day out, uncomplicated back pain. We're usually one of the first line of defenses, and then we send them off to Dr. Whitney. But the main thing we see is people who sit a lot during their day. like was noted before, movement is key. And so getting their joints moving is really important for us, and also their muscles, getting those moving, stretched out, strengthened, stuff like that.
Is that because we're sitting so much more than we ever used to?
Yeah, our bodies are made to move, right? And we're not made to be so stationary, and we are. And so now we're combating that.
So what are some of the signs and symptoms that people should be concerned about other than just an ache, those prolonged conditions or something that may see for more than a few days?
So, the things to look for, of course, would be loss of bowel or bladder function, numbness, tingling, weakness down the legs, or pain that's getting worse or just not getting better. Those would be reasons to come on in and be evaluated, kind of some of the big ones.
Anyone else like to add to that?
Yeah, for me, as well as function, if they're able, to hold their grandchild or perform their work in their daily activities of living. That's a big one for chiropractors, is we got to get them moving.
Is there a certain type of pain to watch for instance, stabbing or dull pain that may be different and that may be a red flag that I need to see somebody about, that this is more than just a slight strain that I might be able to work out?
Along with what was mentioned, the numbness and tingling type pain is something that signifies there may be neurological involvement. There are a lot of descriptions of pain, and the type of pain does kind of clue us into maybe what's going on. Pain that is sharp and really intense, and particularly worse with bending forward, sometimes suggests some instability. So, and if we see that, we try to treat it. Mostly because if we see that, what we know is that that person has an increased risk of future back pain. And so we try to come up with a treatment plan to identify that and help prevent back pain reoccurrences.
Catch it early.
Exactly.
So let's talk about that diagnosis. Once they see, I would guess they'd see their general practitioner possibly first and then be recommended beyond that?
Yeah, usually first line of defense would be either their general doctor or a chiropractor or physical therapist. Often in my world, it's the athletic trainer who sees them first, and then usually we can start with the basic stuff like Dr. Gore was saying, and getting people moving again and doing some of those basic initial type things with a short amount of time off, and then slowly getting them moving. And that's usually where they'll start. And if they're not continuing to improve, then they kind of get sent on. So
talk about the process of being diagnosed. I guess, how do you look for those problems? Are there tests that people can go through? What are we watching for?
Well, I like I said earlier, I'm kind of at the end of the rope. So when I see people in my clinic, people have taken various paths to get there. They might have gone through several steps, they might have not. So one of the basic questions I ask people is, what have you done and what have you tried? By the time they get to a surgeon, typically they've had some sort of imaging study, typically like an MRI or something of their back. And then we can kind of correlate the symptoms. Is it something, numbness, tingling, nerve root, irritation, something like that, where that might be concerning, and can we correlate that with a picture? So I'm usually looking for that history, kind of that over time, what have they tried, who have they seen, and can we correlate that to a physical, abnormality on a picture to put the story together.
Ryan, what type of tests other than MRI would a patient go through?
Well, for me, the most important part is the history and exam, doing a good, thorough musculoskeletal examination, and the history provides most of the information. Imaging supports, our diagnoses that we are based on history and examination. Occasionally, patients have nerve symptoms that maybe not be quite clear based on the history and exam, and we'll do electrodiagnostic testing, which tests the nerves and the limbs to give us more information about nerve function.
So what's that process like?
Well, the nerve tests, it doesn't sound pleasant, but it's not as bad as it sounds, but we apply little static shocks to the nerves, record how fast it travels, and then put little thin needle into the muscle and listen to the nerves communicate with the muscles. It'll give us information if there's nerve damage coming from the back or other places.
That's interesting. Is that a fairly new technique?
No, it's been around for quite a while. Yeah.
And what else might be available?
For me, for a comprehensive back pain, especially if you're chronic back pain that's not necessarily mechanical in nature, we explore other options such as inflammatory pain, and there's certain labs we test for that. Certain hormonal deficiencies and vitamin D deficiencies sometimes can be associated with back pain. So we'll occasionally do a lab workup if that's suspected.
We're hard on our backs, aren't we?
Yeah, definitely.
Yeah. Other than the sitting issue, what types of injuries or conditions might contribute to having back pain?
Back pain, it can be anything from a fall, slip on the ice and fall, shoveling snow, that was the recent thing. Car accidents, I see a lot of those. Work injuries, whether it be something traumatic or whether it be a repetitive overstrain type thing of, you know, typing all day and now you have carpal tunnel type symptoms. So there's, yeah, it runs the gambit.
So the best thing would probably be to start with preventative measures.
Yeah.
And what kind of things can we do?
So I think that's very important to talk about, because that just kind of highlights the importance of people taking, kind of driver's seat with their health and saying, all right, what can I do to prevent this beforehand? And they do much better when it does come. And so the things that I like to focus on first would be physical activity. So like Dr. Gore said, a lot of the back pain nowadays is from inactivity. So if we get people moving, even just little amounts, so getting up and walking a little more than you used to, just becoming more active in general. So that's the first thing, so just physical activity. And that's near and dear to my heart, sports medicine, because I feel that is good for, I think exercise is the best medicine. So physical activity. The next thing would be just general health. That's something we often forget about, things like a healthy, well-balanced diet, adequate water intake, appropriate sleep, maintaining a healthy weight, quitting smoking, these kind of big ticket things that we often just forget about. But if our bodies aren't getting what they need, they're going to start breaking down and they're not going to repair as quick. And so the basic health is really important too. And then the last thing would just be kind of your day-to-day posture and with what you're doing.
As soon as you say posture, we want to sit up straight.
I think, and this could look different for people, people sitting at a desk all day. So that matters. What is your body positioning throughout the day? And that could set you up. And same thing for somebody doing a lot of heavy labor. If you're lifting, are you doing that right? Are you using your legs and not your back? Or even for an athlete, and so do you have appropriately fitting equipment, or is your form good when you're doing your sport? And so all those things kind of play into the prevention, which is our goal, that this never happens, even though it probably will sometime in your life.
Is it true that lower back pain is one of the most self-treatable conditions? Something I read recently?
Yeah.
Yeah. And because of the strain issues and the sitting issues, that we can probably take that into our own hands and really strengthen those muscles.
For sure, yeah, and I think it is one of these things that we know that the body usually gets better on its own with time and some of the basic things. And so that certainly is something that people can treat by themselves.
Yep, definitely. At least in my practice, a lot of the time I try to address nutrition and give them supplements that can help reduce the inflammation, which can cause some of your pain. So inflammation is just that swelling, whether it be vitamin D, fish oil, vitamin C, the water like he was talking about. And then a lot of stuff that they can do on their own is heat, ice, stretching, that movement we keep bringing up, that's important. But there is so much that you can do. There's topical creams that are more natural to start there. And I give my patients at least one of each of those before they leave. I try to give them a nutritional advice, a movement piece, a stretching piece, postural piece, because it all ties in together. And if we can get rid of it, why not? Why not start there?
And you are a fan of some of the supplements that are available?
Definitely, yeah. I think they should be the first line of defense. I think second line of defense should be those over-the-counter anti-inflammatories and pills of that sense. And then from there, I would refer out, because that's not in my scope of practice. That's not what I deal with. So nutrition can be very powerful. Food is fuel for sure, and that's what it used to be back in the day. So why not start there?
Dr. Barnes?
Yeah, totally agree. there's a lot of missing literature on the role of diet and pain, but I think most people that work in the field is just sort of anecdotally and suspect that there's relationship. And so I'm interested to see over time, when there's more literature coming out, like what exactly is the role of diet in pain. But most people now would consider the anti-inflammatory diet, low in sugar, low in processed foods, flour, high in fruits, vegetables, nuts, all the healthy things.
Yeah, we're hearing a lot about turmeric and cinnamon coming into play, some of those things. Would you recommend any of those?
Yes, from the standpoint of that it's probably not going to be harmful, but I would caution patients that the evidence is not there yet. So, it's low risk, questionable benefit, and probably wouldn't hurt and could be beneficial.
And surgically, if they do find their way into your office, Dr. Whitney, what is new surgery-wise? Because that can be very frightening for a patient.
Yeah, so we've, obviously surgery has a long history, and we've learned along the way. I will kind of step back for just a second and say I think it's good to, I'm glad we're talking about all this kind of that, going back to that team effort, because avoiding surgery is a lot better than anything else. I tell my patients that I can never turn back the clock. I can't make you better than you were. We're taking a suboptimal solution to a problem. So yeah, we'll try to fix something, but it's better if you can have a good activity level throughout your life and good diet and prevent a problem, or if you need surgery eventually on your back, if you've done these things along the way, you'll do better in surgery and recover faster. So yeah, but getting back to your question, there's a lot of things that we do now that we've learned from experience. One of which trying to have smaller incisions and be less invasive or less disruptive to the tissue around the spine. Obviously, the spine is kind of in the middle of your body, so we have to get there somehow. Often that's going through muscle or spreading muscle fiber, which then causes postoperative pain and is hard to get to recover from. So we try to find ways to get the work done, but cause less of the collateral damage around.
But it has become much more safe in recent years, and those techniques are certainly helping with that. Well, we have our first phone call tonight coming in from Fred in Calgary. Hi, Fred.
Hello.
Thank you for calling.
Thank you for taking my call. My question is pertaining to my back. It isn't so much pain, probably inflammatory, but I have a narrowing between the third and fourth vertebrae pinching the nerve, which affects my thumb, index, and forefinger on both hands. So I've got a numbing and tingling on a constant basis, and a numbness in those fingers. It's almost like tunnel syndrome, and I wonder what possibly could be done to alleviate the situation.
All right, thank you, Fred. Who would like to take Fred's call?
I'll tackle that one. Hi, Fred. I'm assuming that you mean in the neck, I think is what he said, third and fourth vertebrae in the neck. So obviously I'm a surgeon, so I'm trying to imagine the MRI scan, the CT scan. There is a lot of things to think about surgically from that standpoint, surgically and anatomically. So it just depends on how bad the narrowing is. I will say that things in your neck and down your arms can mimic each other. Like Fred said, like a carpal tunnel syndrome or nerve compression syndrome, which is more a peripheral nerve issue versus in the spine. And so some of those, if you walked into my office, I might get one of those nerve studies to see where is the problem, because sometimes a picture will show something, but the problem is actually somewhere else. So often in my practice, in your situation, Fred, that would end up being a surgery if it was bad enough, if the narrowing was bad enough, just to maintain function. So there's little warning signs there that just make me think that something should, at least be considered. But short of that, I think a lot of these other non-surgical options are usually the first way to start. As long as there's no dangerous warning signs of paralysis or something like that, then if you can do something else, therapy, posture, something else, to try to treat the symptoms first.
Dr. Gore, is that an adjustment you could make?
So not so much a typical chiropractic adjustment. If it's The nerve compression is coming from what's called a disc herniation, so the disc is bulging out and pushing on that nerve. We can do what's called traction therapy, so we kind of elongate the spine to help relieve some of that pressure on the nerve temporarily, and if we do it enough times, sometimes that heals on its own, and so surgery is not warranted. If it's coming from arthritis in the neck, so the bone can actually grow out and push on the nerve, then there's not a whole lot I can do for that, so then I would have to send him your way.
It's an unusual area. Is there any stretching exercise or anything that may help?
I don't know, especially with his symptoms that sound, pretty significant. I think I would probably just start with the really basic stuff. I wouldn't go too hard, but even some of the posture things, as far as kind of neck down, head back a little more. Other basic stretches, but I don't have any offhand. I guess I'd show them.
Okay. We have Elena here in Spokane. Hi, Elena.
Hi.
Thank you for calling.
Oh, thank you guys for having actually something on here that it's like I can attune to.
Okay, you have a question?
Yeah, I was wondering why there's not more physicians in the Spokane area that deal with scapular dyskinesis, especially for people who are hyperflexive, or some people call Ehlers-Danlos syndrome.
That's a great question, and so that's actually a poorly understood phenomenon. And so I guess briefly to explain what she's talking about is that your scapula, so your shoulder blade, when your arm moves up, so shoulder blade here, arm, your humerus here, as you lift your arm out to the side, your scapula has to move. And so it actually rotates 1 degree for every 2 degrees your arm comes up. If your scapula didn't move, you could only get up to about here. You couldn't ever reach up above your head. And so what she's talking about is that the scapulas just don't move like they should, so they move a little more choppy. And sometimes this can manifest as shoulder pain and sometimes upper back pain. And so I think this is becoming more understood, and so there actually are a lot of physical therapists in Spokane who actually understand this really well, and chiropractors and physicians. And so thankfully it's becoming more known, rather than just what's happening right at the site, but looking more kind of upstream.
So we should start to see a few more doctors possibly
I certainly think so. Yeah, and it's one of those places where often people will have shoulder pain, it's just not getting better. And then when we kind of fix that, whether it's a trigger point up in the back or something else where their motion is just not correct, then their shoulder pain magically gets better. So
I would suggest, I agree with the physician for diagnosing shoulder pain. The physical therapist would be the avenue to really focus on scapular motion, because that's definitely their skill set. Most physical therapists will understand what scapular dyskinesia is and have a basic idea of rehabilitation.
Well, excellent. Keith here in Spokane. Hi, Keith.
Good evening. I'd like to delve into compression fractures and the healing thereof. I had 2 compression fractures diagnosed in early spring 3 years ago, and have been through chiropractor and been seen a number of different doctors. And I'm wondering whether there's anything that would counter the argument or the diagnosis that it's just something that has to heal over time. I believe it's correct that the pain that I'm still having right now is mostly muscular pain, compensating for whatever weakness there might be in the compressions. These are in the real low, like 3 and 5, something like that. So I just would really like to hear some observations on how long I must, I'm going to have to be dealing with this. I have plenty of mobility, can do lots of things, but there's certain things that I just avoid, knowing that they will just create more pain.
All right, thank you, Keith. Dr. Barnes.
So you're right about compression fractures do improve with time. Shouldn't be 3 years though. Most compression fractures, most people experience spontaneous relief of the pain within like 50% within 6 weeks. Usually about 3 months, most people are better. In my experience, there's the management of the acute compression fracture, and there's a lot of things you can do for that. Our interventional radiologist can stick a needle in there, inject cement, and it does seem to work pretty well for the acute pain. If you're having pain 3 years out, my question would be exactly what you're saying. Where's the pain coming from? It's unlikely coming from the compression fracture. But what happens is when there's a compression fracture, it changes the kind of biomechanics, change the mechanics of the spine, can change some postural changes, and so that can cause secondary problems. Sometimes it's muscular, sometimes it can cause increased load on the facet joints. When it's closer, higher up to the thoracic spine, I see a lot of rib problems related to that. So the first question would be the diagnostic question about where the pain's coming from, and then with that answer, you could proceed with specific treatment options.
Okay.
So can I just
Please.
real quick, because my ears perked up when you said compression fractures, because I deal a lot with this with people who've kind of got to the end of the road. So basically what you were referring to, in my mind, I think about that as spinal balance. So just a 30,000-foot view, when I talk to patients, I kind of describe your spine keeps everything balanced above your pelvis. So when you have a compression fracture, and it depends on how bad the compression fracture is it a mild thing, is it a major thing, it will change the angles of your spine, like you're saying. It changes the biomechanics, and what are the facet joints taking more pressure. But that can actually throw off your spinal balance enough where your muscles have to work harder. So unfortunately, yes, I think I often tell people that you're going to deal with this at some level for the rest of your life, especially if they've exhausted everything and they're talking to me now. It's obviously bad enough, 3 years. But I think just to, I guess I would part of it is managing expectations and knowing I'm not looking for a magical cure, especially if it's gone this long and it didn't go away on its own. There might be something else. You're doing what you want to do. You're able to be active and flexible. That's good. Just to, in the back of your mind, this is probably something that's real. I'm just to tell yourself, I'm not the same as I was before. And there's a good reason for it. It's normal. It's fine. It's to be expected. But it's kind of this spinal balance idea of what I think about.
Okay. We have Debbie in Malo, Washington. Hi, Debbie.
Hi. Thank you for allowing me to ask my question.
Absolutely.
I am an old ballet dancer, and I have, I've had hip replacements, and my ankles are bothering me. But right now, my back, I know I have arthritis in the very low spine. My question is, can pain in your back and misalignment, can it wrap around into your intestine area? Because I've been to doctors and they say, well, we can't find anything, and I've had a colonoscopy and so on and so forth. So I'm just left with my question, can it come from my back?
And you're having intestinal problems?
Not problem, pain.
Pain in your intestine.
Yes.
When I hear that, a lot of times we have what's called our hip flexors, and those muscles actually attach to the front of our lumbar spine. So the front of that spine in your low back, and then into your hips. So when those are really, really tight, a lot of people complain of intestinal pain, or if they're women, uterine pain. And I'll get into those muscles, get them to relax, and that relieves a lot of the pain. Not only that, is with something where you have a lot of wear and tear and arthritis in throughout the lumbar spine, I would take a look at the pelvis too, to make sure that those large joints called your sacroiliac joints in your pelvis are moving. Because a lot of times with increased sitting or any type of trauma, those joints actually kind of lock up or restrict, and they aren't moving quite as well as they should. And so the area adjacent, or in your case above it, has to compensate and move a little bit more, and it gets that wear and tear, and then those muscles tighten up to try to protect and splint it. So getting that pelvis balanced and getting those muscles relaxed and maybe some strengthening so that they can support what you need.
Yeah, so she may benefit from a chiropractic adjustment then.
Definitely,
Okay.
yeah.
Well, getting relief from back pain isn't always easy, especially when the pain comes and goes. Spokane man battled back pain for almost 30 years. He bounced from one doctor to another. Tonight, his journey to better health and how exercise helped him feel better.
To see Dave Fody in action, you'd never know that he's battled back pain most of his life. Dave's a regular at Giorgio's Fitness. He's also an avid biker who's been known to put in 100 miles in one day.
I feel good, I feel great.
He says he finally got real relief from his back pain about a year ago.
I can go out and work on a car, work on my house, and not worry about things. Things are solid, and all that pain stuff is not holding me back anymore.
But getting there took decades of searching. It started with an injury on the job.
Yeah, I was 23 years old at work, and long story short, a truck and a bulldozer, and I was in between, and I got squished right at the pelvis.
Dave was rushed to the ER. His back wasn't broken, and while sore for a few weeks, he was able to get back to work.
I felt I was lucky.
In the years to come, the back pain would return. And when it did, Dave found relief through chiropractic.
I was able to deal with that through late 20s, early 30s.
But it never really went away.
You'd wake up in the middle of the night with some back pain, but you just dealt with it, and because you got life to live, right?
Still struggling, Dave knew he needed to make a change.
Well, it was spring 2013. I was kind of that sick and tired of being sick and tired. So I just told myself to suck it up. I was almost 240 pounds. So I decided that I'm going to just start exercising, start eating better, and it started to work.
Until a day of golfing triggered the back pain again, and worse than ever.
The motion of golf, swinging that club, something let loose in there.
In a matter of days, Dave had x-rays, an MRI, and surgery.
And I woke up feeling amazing, amazing. I had no idea what pain I was in. It was like a new lease on life kind of thing.
Dave had suffered a ruptured disc. Feeling better, he went back to exercising, even training for a half Ironman. But eventually, the pain came back.
I was going for longer 9-mile, 10-mile runs. Now I'm starting to have numbness in my feet. I'm starting to have cramping in the calves again. I'm like, man, what's going on here?
A new round of x-rays and MRIs brought a diagnosis of degenerative disc disease. Still in hefty pain, Dave explored his options. It took months as he interviewed doctors and battled insurance. In March of 2017, he finally got the surgery he needed, and best of all, real relief. Which brings us back to Dave's passion for exercising, something that's kept him going all these years.
Stay active. That's, I think, 75-80% of the battle right there.
Well, I think all of you can speak to Dave's story. You had a little piece of everything in there with that 30-year battle, and exercise playing a big role.
Yeah, no, I think that's a great story, and I think that just highlights the fact of how important movement is. And often it's just going back to those simple things. Of course, when needed, just like he did, to seek other treatment. But great story.
Mm-hmm. Is it a common story? 30 years is a long time.
Yeah, especially patients I see, that's very normal. It's been, for a lot of them, it's been a very long time, and unfortunately, it's been this kind of battle for a lot of people, trying this and trying that. But
so a common thread running through that story, and again, he had chiropractic treatment, he had surgery, kind of went through the full gamut before finding, well, and 2 different surgeries, I think he mentioned.
Yep.
Yeah, wow, quite a story. We have Audrey in Spokane calling in with a question. Hi, Audrey.
Hi. Thank you so much for allowing me to speak. I am an 87-year-old lady who has had back problems all my life, and started with in my neck when I was about 20, and then just everything calmed down for a few years, and it's gone on and on. I can't go into any real diagnosis or talk about it because of the fact that it would take me all night. But for the most part, I'm a very healthy lady still, but I'm beginning to have problems with walking, feeling like my hip is bothering me. Also, 10 years ago, I had my right knee operated on and had it replaced or whatever they did then, and that was fine. It's been good up until now, but it's starting to hurt. Also, in my groin, it hurts, and I just don't quite get the connection. I was in the medical field a little bit for about 25 years, but I was doing transcriptions, so I'm only knew what the doctors were saying, not that I really understood all of it, but still I'm very interested in why the groin is involved in this, and if all of this that I'm feeling in my right leg and hip is connected, and I would like to know about that.
All right. Thank you very much for your call, Audrey. Dr. Barnes?
That's a very good question, and sometimes it's a diagnostic challenge to tease this out. There's a few things that can cause pain in the groin. The hip joint can do it, the SI joint can do it, it can be referred from the back. And it gets even more complicated where a lot of times there may be two different things going on, and one's aggravating the other, and trying to tease that all out takes a little bit of work. My recommendation would be see either a musculoskeletal specialist or sports medicine specialist for a thorough examination, and part of the history and exam will be assessing for those different potential causes. Sometimes we use imaging, diagnostic injections to help tease out the primary pain problem, along with a treatment plan once diagnosis is established.
Okay. We want to take an email now from Oscar in Spokane, and Oscar says, how important is patience when dealing with back issues? I have 3 bulging discs, one in the L5, S1 disc. Other injections failed. My first doctor suggested surgery. However, my second opinion doctor said exhaust other options first. And that's from Oscar.
Maybe I'll speak to that first, right? All of us can. Research has been done about discs, and the gist of it is, well, I'll go back to one study. I forget exactly what year it was, but they had thousands of patients across the country, and anybody who had a herniated disc and pain and was missing work because of it. 2 groups of people who had non-surgical treatment, people who had surgical treatment. And about 2 years after this all started for those patients, they were all at the same place. So Oscar's question of patience, I think patience is the key word. And not knowing the exact details, if there was some acute problem with the nerve compression or something from the disc, barring that, it's really not an emergency to take care of. And I think patience is a good option. Now, during that time of patience, a lot of these other things we've been talking about could actually be helpful and might get Oscar through that without needing surgery, actually. So I think I'm not second guessing any one surgeon's opinion, because there's all opinions are valid, but there's no harm in waiting. There's no harm in patience.
How long? I mean, how do you gauge that?
Well, I'm going to give one of my biases here. What I tell a lot of patients, surgery should not be thought of as curing pain in your back. It's kind of my bias. There's a lot of people do get complete relief of pain if they have surgery, if they get to that point. But I think that's not the reason to do surgery. So, surgery is more indicated for some acute issue, something that can't be treated with these other methods. So, I guess that's just kind of my bias going into it of basically try to avoid surgery if at all possible. Now, it might be necessary, but I think Oscar's point of patience is kind of the key point.
There's so much fear, it seems like, especially with back issues, because it is such a tender area of the body. even going to chiropractors, people are afraid of that. There's some fear involved. I'm sure you've heard all of it. What are you doing to my body? What exactly, when you are doing an adjustment, are you putting bones back into place? What takes place? What are you doing?
So bone out of place model is a little old. Basically what we're doing is, like we've been talking about all night, inducing motion. So sometimes people will say you're out of alignment.
Yeah,
but
you hear that a lot.
You hear that a lot. But what really is going on, in the way I think about it, is some joints are locked up, they're stuck, they're kind of fused temporarily, and other joints are imbalanced and they're moving too much. And so what we do is we kind of balance that out. And so through the chiropractic adjustment, I understand it can be scary for people, and I deal with that every day. It's hard to give up, especially your head and neck, but a body part to somebody else. It's instinctual not to, right? And with the chiropractic adjustment, you just relax, and we provide, it's called an HVLA, high velocity, low amplitude force in a specific direction in that joint to get it moving again, to take the pressure off the above or below levels that are moving too much, and to balance everything out. Sometimes you hear a pop, it's called a cavitation, and it's just when the fluid turns to gas in the joint and it forms this bubble and it makes that sound. And so it's just a bubble, it's nothing too scary. The chiropractic adjustment shouldn't hurt. Sometimes it can be a little tender if you have some inflammation in around there, but usually people have a big sigh of relief afterwards. So.
Is it a myth? Because you hear also quite often that once you start going to the chiropractor, you have to keep going. Is that true?
So the way I practice is, I always tell my patients, I love seeing you, but I want to get you better and see more people and help even more people, because there's 80% of the population will have back pain at one point in their life. So if I can treat more people and get to help more people, that's my goal. I want to see you a little more often in the beginning, taper out your visits, and then give you the tools to heal on your own at home, the strengthening, the stretching. Just kind of like when you go to the dentist, you're supposed to brush and floss to avoid a cavity. But once you get a cavity, you can't get rid of that on your own with brushing and flossing. Just like that joint restriction or imbalance, you can't usually get rid of that with stretching or exercise, but once we get you going, then you can maintain it on your own.
Very good, very good. We have another email coming in from Keith. I see a lot of advertising for laser spine surgery. Comments?
Well, I'll speak to that since I actually get that question a lot too in clinic. So I do not do laser spine surgery, but I have talked to people who have had it done. So this, obviously I'm not the best person to answer the question per se, but my understanding of what laser spine surgery is basically a minimally invasive procedure, trying to, like we said earlier, about keeping damage to the tissues around it minimal. But really the point is frequently to decompress a nerve, where a nerve is getting pinched in the back. So, or I might use a knife to do that, or a drill to do that. They're using a laser to do the same thing. So the ultimate result is to decompress a nerve, free up some compression, and obviously to do that as minimally invasive as possible.
Okay. Anyone else know any details about spine or laser surgery? Okay.
I know, not a whole bunch, I know there's very little literature out on it, whereas there's decades and decades of research from the neurosurgical field. And so I have reservations about concerns about it, especially when a lot of the surgeons are already using minimally invasive technology.
Okay. We spend so much time sleeping. How important is a good bed, or a specific kind of bed, and sleep position and that sort of thing, to make sure that we keep from having back pain?
I'll at least say my piece. I think first off, it's something to be careful about. If you've ever been into a mattress store, you can see how it's like buying a new car. It could be very expensive. So I think
there's a wide range.
There's a very wide range, yeah. And so I think it's just one of the pieces of the puzzle. And so the big thing is, try out a couple. It should be something that's comfortable and that you can afford. And as far as sleeping positions, everyone's a little different, but usually it's going to be, something, on your side and with kind of your body in alignment. Often people sleeping on their front, that can cause some problems. But everyone's a little different. I think just comfort and you kind of know for yourself.
So you're not looking for that support, lower back support, or?
Yeah.
I think
it's going to be a comfort issue.
There's some research, but very limited evidence. But in general, medium firm, maybe firm for some people. Some people have increased pain from the pressure in firm, but the medium firm beds, I would echo the price thing. I did some mattress shopping years ago, and we, the $800 mattress, it's just as good as the $5,000 for the firmness and quality. But other than that, there's no great. I would say if you have an old mattress, and I have personal experience with this, in medical school, we had little money, and then had an old mattress, and my current wife and I
dip in the middle.
Yep, and it had a dip in the middle, and my wife and I woke up every morning with backaches, and so and that went away with a decent mattress. So. There's no really great guidance on other than if you have pain in the morning and your mattress is pretty old, it's reasonable to change it. And as far as the type is, soft mattresses usually don't provide the same type of support as a medium firm or firm mattress.
Mm-hmm. Yeah, what I tell my patients is, test it out, lay on the bed, and if you lay on your back, if you feel that it fills up the curve in your small back there, and is supportive but still comfortable enough to sleep, that's going to be good. If you're on your side, same thing, make sure the curves are supported, maybe putting a pillow between your knees so that your hips are aligned up with your pelvis a little easier, and then making sure that you have a good supportive pillow under your head. Because a lot of times I see almost every day is people, I woke up with this pain, and it's because their pillow's not supportive, so their neck's crunched over, they're folded over forward, and that produces some pain. So making sure you're basically, like Dr. Barnes was saying, is that your spine's in alignment is the best option.
Just as important to have a good pillow then as a good mattress too. Okay, that's good advice. We have a call from Jeremy in Elk. Hi, Jeremy.
Hi.
You have a question?
Yeah, I have a question. I'm wondering if my left sciatic nerve has anything to do with my lower back pain on my left side.
Okay, just that simple. Anything else?
I have my wife has something wrong with her neck. Usually, it seems like it's a C3. We're wondering if you guys know anything about that. And the vestibular system.
Okay, so we have twofold question from Jeremy. First, the sciatica.
I can answer the sciatica question. So for me, when people come in with a complaint of sciatica means leg pain to me, and that's all it means. And then so the differential for leg pain is actually fairly broad. Most people automatically assume it's from a nerve, but there's a variety of things that can mimic nerve pain down the leg. So sometimes the muscles that attach to the side of the hip, when it gets painful there, can look like a L5 nerve root problem. Hip joint pain, a lot of times frequently mimics, can refer down the leg, SI joint. There's a lot of things to assess for. And so the answer to the question, yes, it could be from a nerve problem, but then there's a variety of other potential problems that you need to see a physician to kind of sort of tease out.
Okay. We haven't talked about medications available if you do have persistent pain other than going through rehab or surgery. What is recommended as far as over-the-counter or prescribed medications? So
medications, unfortunately, if you look at the overall benefit of medications, it's really modest. Sometimes can be helpful. Now, guidelines recommend over-the-counter Tylenol, NSAIDs for a period of time. Now, I have a thing against NSAIDs. That would be ibuprofen, Aleve, naproxen's Aleve. These over-the-counter, they seem harmless, but actually can be quite dangerous. There's a lot of deaths every year from complications from NSAIDs, so I'd be very careful with those medications. When we talk about medication management, we distinguish between acute, pain versus chronic. For acute pain, we're talking about, hey, we just need 2, maybe 3 weeks of something. We have a wide variety of options from muscle relaxers. When someone's really miserable, we can use the stronger painkillers, the opioids, which carry higher risk. Chronic pain, a little different. The benefits start becoming a little less, but there are certain options I use. that work on the nervous system, because the nervous system actually is thought to be playing a larger role in chronic pain than we ever assumed before. You know, before it was thought it's something wrong with the muscles, something wrong with the spine, something wrong with the SI joint. But if we look a little more, it seems to be there's a sensitization of the nervous system involved with a lot of forms of chronic pain. And so the medications that have been so helpful for chronic pain usually work on the nervous system in some way, trying to reverse some of that sensitivity.
What about biologics?
What do you mean by biologics?
Well,
that goes all over the place.
I know.
So I think just to piggyback on what he was saying, medication is great on the short term, and then beyond that, then you start to wonder: are we just masking something that should be treated some other way? Now, some people need to be on chronic medication. There's a role for that, but I think before you start jumping to that, you just need to really look at the underlying problem. Have we diagnosed the correct thing? Are we chasing the right problem? And before we just start masking it. Biologics are newer and kind of all over the place, and kind of like we were saying earlier about lasers and things like this. Just it's good to be careful and just look at the research underneath them.
Okay. We have an email from Lynn, and Lynn says, what are your thoughts regarding the use of inversion tables for back relief? Are there concerns that users should be mindful when using this type of therapy? First of all, explain what she's talking about.
I'd be careful not to get stuck on one of those.
It's where you flip upside down,
yeah, it's where you flip
right?
upside down. So I know, for that, as far as the evidence saying, does this help with acute or chronic low back pain, it's not there. Could it help some people? Like Dr. Gore was talking about as far as kind of lengthening out the spine. I think in certain cases it certainly could. I would be careful with that, though. The amount of time you're spending on it. We're meant to be upright beings and should spend most of our time that way other than sleeping. But
I bet you get that question a lot too.
Yeah, I definitely want people to start out slow with it. Definitely go into a practitioner of some kind, whether it be a chiropractor or a musculoskeletal specialist, to kind of have them let you know if it's safe for you and what's going on with you. But I tell my patients that it's safe for, don't go all the way upside down on your first go. Don't be there for an hour. Start with 3 minutes and start with maybe even just 60 degrees. Everyone's a little different. Be down there for 30 seconds, up for 30 seconds, back and forth. So start really slow and make sure it's right for you. Get checked out first.
Can it be dangerous? I mean, being upside down, blood going into the head and all that?
It depends on each person. Okay. There are certain things where it can make you feel a little worse. Yeah, so that's why I say get checked out first.
Okay. Yeah. Phone call from Joseph in Calgary. Hi, Joseph. Are you there? We may have lost Joseph. Okay, we will move on. Let's talk about, again, something we often do, which is driving. We spend a lot of time in our cars. Let's talk about it. Are there any supports we can have in the car that take some of the strain off of our backs when we're driving?
I think just a comfortable position is important. So to make sure that the back is straight, so perhaps a lumbar support or a towel roll or something soft to give that lumbar support. Or a lot of cars have it nowadays. Another thing I commonly see people wearing, men with big, huge wallets, and just sticking in your SI joint or whatever.
Throwing everything out of kilt.
So being careful with that. And then also if you're doing a long road trip and you can take breaks, get out, walk around for a little bit and get out. Or just keep moving, especially if you're a passenger, keep your legs moving, do some stretches. Yeah.
Make that drive productive.
Exactly. Yeah, keep moving. Yeah. And I'd say the same thing on an airplane. Get up, stand, every hour at least.
Yeah. Okay, very good.
Add a little bit to that. I really, I have a lumbar support in my car, but something to know about back pain is something that you see from most people will tell you if they have back pain is that stationary positions aggravate their pain. Standing in place and sitting in place. And the theory is behind when you get in these positions, we're loading certain structures and the structures can handle that load for a period of time. But over a long period of time, we create injury. So I think even if you don't have back pain, but especially if you have back pain, you should be aware of that. And so there's this concept of posture awareness, how you're sitting, and I agree with the moving around. Another thing that can work really well is just simple pelvic motion here. Move your pelvis forward, pelvis back, to the side, and that will actually offload and reset some of those.
So just so you're not in that exact same position all the time.
Exactly.
Mm-hmm. And that makes me think of lifting too, and being very careful when we're lifting. Is it still a leg down with the knees and lift?
Yes, it's definitely. I always tell people, stick your bum out first. I mean, it's a big muscle for a reason. We're supposed to hinge at the hip and not bend our lumbar spine. So we're supposed to stick our bum out, use our thighs, the big muscles, you know, not the muscles in our back, and keep whatever load you're lifting close to the body, close to the center of your gravity, which is your belly button. So you don't want to be hanging out here. That puts a lot of strain on your back. So just keeping it close in, keeping your posture, shoulders down and back, and maintaining that core braced as well.
Mm-hmm. And then we're going to start hitting training for Bloomsday, golf courses. What do we need to keep in mind?
So back pain, just like the general public, is very common in athletes. And so, you know, as far as there's some high-risk sports, you can imagine anything with twisting, so things like golf, and gymnastics, figure skating, those type of things. Or like we were saying, lifting, so you're lifting heavy weights, a weightlifter, especially football offensive linemen, believe it or not. So over 50% of them have some chronic back issue because they're doing a lot of this extension, kind of getting up, and they're just big guys. In general, I'd say the same things apply as far as, you know, making the basic health type things we've talked about, and then just keeping a close eye on how your back feels. If it feels really tight after a run or after something where you maybe trained a little too hard, then things like heat packs. Maybe that night, or a short course of anti-inflammatory medications, even for a day or two. But just taking care of it early, I guess, and then allowing your body appropriate time to rest. Take a day off before you try to train again. And then just going back to some of those basics that we talked about.
Absolutely.
But keep moving.
Take it slow and keep moving.
Exactly.
Well, it's excellent advice. And that is actually going to wrap it up for us. We have come to the end of our discussion, and that's going to do it for this show. I want to thank the panel for a great discussion tonight, and our thanks as well to everybody who called or emailed in questions. And we will be back next month with another edition of Health Matters. Join us April 19th when our topic will be Alzheimer's disease. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
I'm Pearson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.